Hey there, rock stars. I just wanted to do a brief, well, sometimes I rattle on, so it might not be so brief, but a review of some of the pharmacology that we give for ventilation problems. A lot of times we receive our pharmacology knowledge early in the curriculum, and then we don't have the opportunity to apply it to real patients until second, third, or fourth semester of a nursing curriculum. And by that time it gets, well, it falls out of our brain. Okay, so quick refresher on the ventilation pharmacology. So we're going to see this used in disorders that are constricting. So this would be like our COPD patients, which could be chronic bronchitis, emphysema, asthma. We'll even see it with our patients, some of these medications with cystic fibrosis as well. When it comes down to it, we can really lump our pharmacology for this subject under bronchodilators and our anti-inflammatory medications. So we'll separate it right there in those two parent categories. So we're going to start with the bronchodilators. The first one is our beta-2 adrenergic agonist. Okay, so let's take a second just to go through that word. Beta-2, it's not selective to just like a beta-1. Beta-2 is going to affect the lungs as well. Adrenergic, that word has a lot to do with having to do with catecholamines, norepinephrine and epinephrine. So very similar to the fight or flight system or the sympathetic nervous system. An agonist means to encourage. So we are going to encourage beta-2 activity. Okay, so what does that mean? What does the activation of beta-2 do? Well, if you think about it, a lot of it is the opposite of a beta blocker, obviously, because you're encouraging as opposed to blocking. So when we're looking at the body, it's going to bronchodilate. Okay, so these are bronchodilators. But we want to look too at what could happen if we get higher doses of this med. What are the effects of beta-2 on other systems? What could be some of our side effects? So we know that beta-2 in other systems, like our heart, it's going to cause vasoconstriction. So it's going to make that blood pressure go up, and it's going to make that heart rate go up. It's going to make them a little tachycardic. Also, it's just everything that you see with like a sympathetic reaction. You might have the gut dump. You might feel a little shaky, feel a little nervous, all those things that are activating the fight or flight system there. Our medications that fall under this are prototype medications, and most common ones would be albuterol, formoterol, and salmeterol. Okay, so those are all three are very common beta-2 adrenergic agonist. Other medications that we might see used are anticholinergic medications. Ipratropium and tiotropium are two of the prototype medications for this. With those anticholinergic meds, how do they work? They too are bronchodilators, but they work like by blocking acetylcholine. And if you remember, acetylcholine is what makes our parasympathetic system works. So we're doing the opposite of that. So again, we're kind of pushing them into that sympathetic response there. So let's compare and contrast cholinergics versus anticholinergics. Okay, so cholinergic activity is that one that we remember with the pneumatic sludge. Okay, salivation, lacrimation, urination, diarrhea, and gastric juices. Okay, ugh, sludge. Okay, those cholinergic effects are going to cause sludge. Anticholinergics are going to be anti-sludge medications. So they are going to cause, among other things, bronchodilation, and then they're going to cause, with anti-sludge, everything's going to get very dry. When we have patients that are on anticholinergics, we really want to watch them for things like dry mouth, that they're able to urinate, that they're able to go to the bathroom, because again, it's going to affect those muscles that allow people to urinate and defecate. So if a person were to take too many anticholinergics, we would be worried about anticholinergic toxicity. And when we see patients who have anticholinergic toxicity, they have some telltale signs, excuse me. So they're usually very flushed. We say they're red as a beet. They're mad as a hatter, meaning that they have some psychosis going on. Hot as a hare. They cannot sweat because everything's dry. And so their temperature increases and they get hypothermic. I like to remember it. My friend taught me this. She said they can't see because you have a dilation of your pupils. You can't see, you can't sit because the psychosis, they can't stay still. Can't see, can't sit, they can't pee, and they can't shit, okay? Because they're all dried up inside. And then we have the methylectines as well. These are an older group of medications. Theophylline and amiophylline are two of these prototype medications. We're not going to see those used quite as much anymore. They have a really, really narrow margin of safety. So you have to get to a certain dose before they work, but after that dose, the toxicity level is really close there. So a very narrow therapeutic margin is what we would call that. And those are your bronchodilators. Okay, let's contrast those with the anti-inflammatory medications that cause bronchodilation because they're anti-inflammatories. So we have our glucocorticoids. Beclomethasone is a prototype one. Orally, we could take prednisone, and then nasally, we have fluticasone as well. These medications are great. They work like all steroids work. And so how do steroids work? What do steroids do? They do work very effectively, but they have a whole slew of side effects. So your steroids are going to tell your immune system, shh, calm down, okay? You're overreacting to this. And in turn, your immune system is going to be dampened. And if you think about it, all those symptoms of your immune system working are the symptoms that make it hard for somebody maybe to breathe because you have that inflammation in your lungs, you have that release of mucus to try to capture that bacteria. But those are the things that make us miserable too. So taking a steroid sure does make somebody feel better because you have that anti-inflammatory effect, less pain because of less inflammation, less swelling, less mucus production. Sure, you're going to feel pretty good, but you've also dampened your immune system. You've said, shh, calm down, immune system. So now you are at risk for other secondary infections as well. Okay, so steroids are definitely a double-edged sword. Now, more specifically are your mast cell stabilizers and your leukotriene modifiers. Now, these do work in a similar fashion as steroids, but they don't dampen everything. They're very specific to mast cells or leukotrienes where they just affect that part. So they work like antihistamines in order to just inhibit part of the inflammatory response. That way we don't have that whole slew of side effects that we do from taking like oral prednisone by decreasing the immune system all over the body. Another problem with taking just those glucocorticoids, too, we worry about a patient developing like thrush in their mouth as well. So the mast cell stabilizers, the leukotriene modifiers, much more specific. A lot of times these are used for chronic asthmatics or COPD patients. So mast cell stabilizer, your prototype medication is cromulin, and your leukotriene modifiers, have your montelukast or zafralast as your newer medications there. I hope I cleared up and helped you to refresh some of your pharmacology that has to do with inflammatory disorders. If you need anything, please let me know. See you later.